evening. Okay. So Dr. Shah Mohammadi talked to us a bit about revascularization, and as Dr. Goldstein said, I just wanted to talk about the steps that come thereafter. After the plumbing is repaired, what does the tissue look like, and how can we make that patient restore his or her quality of life? So our overall goal is really to optimize tissue growth. So again, we've revascularized. The second step, or the second part of our treatment, is medical management, so we'll talk a little bit about that. There's oftentimes some debridement that needs to occur, so we'll talk a bit about that. Cellular repair, those are oftentimes things that can be done outside of the operating room, either in the office or in the clinic setting, to further enhance tissue repair and growth. And some surgical reconstruction, and of course the follow-up and surveillance of all of the above. So Dr. Shah Mohammadi touched briefly on the risk factors. So smoking, of course, is a major one. It's the #1 risk factor. Hyperlipidemia, for which there is medication that patients should be taking to optimize. Hypertension. But also antiplatelet agents, and that's probably the #1 medication #1 type of medication that's important after we revascularize our patients. So aspirin is of course our standard, our go-to medication for peripheral vascular disease. Patients really only need a baby aspirin, 81 milligrams of aspirin daily. The full aspirin, 325, is really for a coronary artery disease. Many of our patients have some dual therapy though, or we use Plavix. So this is just an overview, of where these medications act on the platelets. So there are many different receptors, as you can see here. So aspirin, of course, acting on the COX-1 inhibitor, which is, again, our old standby. Plavix and medications like it act on a P2Y12, so it's an ADP receptor. So again, those patients who are revascularized, perhaps they have coronary artery disease, Plavix is often a go-to medication for them. But then there are the newer medications, some that are not even quite on the market yet, that act on the other receptors. One main reason for that is that there's a degree of Plavix resistance, that these receptors basically become numb to the medications that we're giving them, and so these patients may rethrombose their interventions. So one of the newest ones is Zontivity, is its trade name, and it acts on the PAR1 inhibitor, and it's been shown to have an benefit in coronary artery disease and also peripheral arterial disease. This is just an overview of those. So next, oftentimes when we revascularize these patients, they then become edematous. So we need to take a step back and figure out why that is. It might be for a number of reasons: kidney insufficiency, perhaps the congestive heart failure, but oftentimes after revascularization, the primary reason is because of essentially an ischemia reperfusion injury, such that if you've had a tissue that's been critically ischemic for a long period of time, then you restore blood flow, that the tissue essentially doesn't know how to handle it, so it becomes edematous. So the #1 way to counteract that is compression. So patients who have normal ABIs, as Dr. Shah Mohammadi overviewed, they can have a high level of compression. So that's a 30 to 40 millimeters of mercury, which I'll go over in the next slide. If they have an abnormal ABI, then you can reduce that compression, but still give them some. If they have something that looks like a critical limb ischemia, an ABI of less than 0.5, then compression is not really safe for them, because then we're concerned that we're going to overcome the arterial insufficiency that they have and actually worsen their ischemia. And of course, we'll continue to do their surveillance. So this is just, again, a little bit more in depth about the compression. So a high level of compression is in a clinic setting, a patient particularly who is wounded, it's a 3 to 4 layer compression. So it's multi-layered, it's elastic, it's tight. It's, again, 30 to 40 millimeters of mercury, and that's what most of our studies are done on, 30 to 40 millimeters of mercury, but that's not typically what we put our patients in. We really typically put them in a 20 to 30 millimeters of mercury compression. That's still multi-layered for wounded patients, but it ends up being inelastic, and it's a little bit lower. It's a little bit easier to tolerate. And particularly in patients who are not wounded, then there's the standby compression socks, which typically is 20 to 30 millimeters of mercury. There is a lower grade compression, 15 to 20. That's a non-prescription degree of compression after these patients are healed, or just for standard, particularly patients who have venous insufficiency along with their arterial insufficiency. So just a brief overview of debridement. Again, for patients with wounds, there's that unhealthy tissue. We've restored the blood supply, but then we still have that wound that needs some attention. So the standard is an excisional debridement. So typically, we use something sharp, so a scalpel, a curette. There are other ways now that we can debride. A Versajet is essentially still doing an excisional debridement, but it's sort of a hydro debridement using water as the medium at a high speed to really get rid of that fibrinous exudate or what may have perhaps some infected material. There's also enzymatic debridement. So Santal is a daily medication. It's actually a collagenase that can be applied on the wound. I'm sure it's used very often. And then it slowly debrides, painlessly debrides a patient's wound on a daily basis. There's also ultrasonic debridement. There are at least two primary ones that are used: Sonic 1 by a company, Masonics, Mist Therapy by Aliqua. It's again, not really excisional debridement because there's no cutting, but there's using the ultrasound as the medium being carried by the water, which can cause essentially cavitation of the tissues and again, debride away that unhealthy tissue. The next is growth factor replacement. Now, these things I have to say I haven't personally used, but it's essentially restoring or replacing a patient's PDGF. And PDGF is a growth factor that's gotten a lot of attention, particularly in plastic surgery community, for doing just what it says, repairing cells. It calls a lot of other repair cells to the wound bed. So we can either use a patient's autogenous PDGFE by harvesting their own platelets, which is not reimbursed by CMS, which is of course very important, or there's a medication, Regranex, which is recombinant human PDGF. It's indicated for diabetic foot ulcers. It actually has been shown to improve healing. There's a black box warning, which is very important, that it also has been shown to have an increased incidence of malignancy in its patients. So particularly in patients, it comes in a tube, it's an ointment, particularly in patients that have used 3 tubes or more, then they have been shown to have a higher incidence of malignancy. And that malignancy varies from solid tumors to blood malignancy. So you can understand why perhaps we've been shying away from that. There's a dermal substrate replacement. So we're going to talk about synthetic, xenograft, and then there are some allografts. So in the synthetic world, I think probably what's most often used is Integra. This is essentially what one type of Integra looks like. There's a collagen, and that's what comes into direct contact with the patient's wound. Then it's covered with a silicone. So it's kept on for 3 to 4 weeks so that underneath that collagen and silicone, the patient's granulation tissue is protected and covered and allowed to essentially repair and heal itself. And after you remove the Integra, the hope is that if you need to do something additional, like a split thickness skin graft, that graft can be thinner, the donor site will be easier for the patient to tolerate, et cetera. The xenograft is, of course, coming from a species that is not our own. One of note is Oasis. That's actually a porcine xenograft. It's a dermis. It can be used on it's indicated for a number of different wounds, but primarily I would say used in venous leg ulcerations and diabetic foot ulcerations. It can be applied in a clinic setting, doesn't have to be applied in an operating room, and it has been shown to enhance and increase healing. And then allograft. So again, these are essentially harvest from humans in a number of different ways. So an epifix is essentially from the amnion. Graphics and biovans are placental, but they're essentially taken from human tissues, dehydrated in some way, and then placed on the wound. Again, it doesn't have to be done in an operating room. It can be done in a clinic setting. It can be done in an office setting. But all of these have been shown to enhance healing. These EpiFix and graphics can be used. I primarily see them used in venous leg ulcers and diabetic foot ulcers, particularly EpiFix. It can also be used in burn patients. We have to pay a little bit of attention to how they're reimbursed because they're not reimbursed equally, particularly for Medicare patients. The coverage is a bit different for private insurers, but particularly EpiFix and graphics have been shown to increase wound healing. Temporary cellular replacement, so sort of along the same lines. These are, again, taken from human subjects. So Dermagraft is only indicated for diabetic foot ulcers. It's essentially just dermis. It's taken from human fibroblasts and then grown in a petri dish and then applied to a diabetic foot ulceration, and has been shown in studies to enhance and improve healing. Apligraf is similar. It's taken from human foreskin and grown. It has epithelial cells along with an extracellular membrane. It's indicated for diabetic foot ulcers and venous leg ulcers. Can also be applied in a clinic setting and has been shown to enhance healing. These can be applied several times over the course of a patient's treatment, typically on a weekly basis, so that you can assess the wound, hopefully notice that it's decreasing in size, and then apply again in order to speed up the wound healing. The coverage for these is typically after 6 weeks of a conservative treatment, so that if you demonstrate for 6 weeks, the patient has been revascularized, you're applying their standard wound treatment, and they're still not healing, then we can start using such dermal replacements like this. Surgical reconstruction. So I put total contact casting under sort of the surgical heading because casting is often done in the surgical world, but this is the gold standard for a diabetic foot ulceration. Patients often try to dissuade us from doing this, but it's the best way to diminish the pressure on the ulceration in these patients. We talked a little bit about skin grafting. Again, still comes into play with a lot of these ulcerations, especially post-operatively. Musculocutaneous flaps, particularly done oftentimes by our plastic surgery colleagues. And then hyperbaric oxygen therapy. So hyperbaric oxygen also comes in after a conservative period of treatment has been carried out, and typically it has not been successful. And I'll show on the next slide the indications for hyperbaric oxygen therapy, but particularly, again, in our wounded patients, the basis for it is essentially Henry's law, that you're increasing the pressure under which we're taking in our oxygen, and therefore you increase the amount of oxygen that's dissolved in the tissues. So that improves the amount of oxygen that gets to the tissues. It increases the angiogenesis. It increases those growth factors that we talked about, like PDGF. It increases antimicrobial effects. It actually has been shown to be somewhat bacteriostatic, but also improves and increases the number of leukocytes that they're carrying at that wound bed. And these are the indications. So necrotizing soft tissue infections, so our gas gangrene patients, Clostridial myonecrosis, refractory osteomyelitis. So again, after a standard course of therapy has already occurred, diabetic foot ulcerations that have to show some degree of standard blood flow to the foot, a Wagner grade 3 or greater ulceration for a diabetic foot ulceration. And it used to be arterial insufficiency, but unfortunately at this time, CMS no longer covers that. So that's actually decreased in my practice a lot of patients that I actually can send to be considered for hyperbaric oxygen therapy because then it's not covered. And that decision was actually made relatively recently. It's actually gone retroactive back to January of 2016. So that's been a bit of a disappointment because there actually has been a lot of evidence to show that patients improve with hyperbaric oxygen therapy. And last but certainly not least is surveillance. So our wounded patients we typically see weekly, again, especially if we're applying some of these epidermal or dermal replacement therapies, we want to see how the improvement is carrying out on a week-to-week basis so we can reassess if we should move forward with that treatment or if we should change things. We have to make sure that infection, of course, doesn't occur because that's the most common reason that these patients then need to transition to an inpatient status. But then just regarding our revascularization, we see them constantly. So I always joke with my patients that they're married to me. If I've revascularized them, particularly if they've had an open revascularization, they never get away from me. So our first visit is less than 2 weeks. I typically see them in 1 to 2 weeks. And then typically, again, especially for our wounded patients, for that first year, it's every 3 months. We do some sort of surveillance study, and after they make it through the first year and with hopefully no negative events, then we might see them yearly. We might start to space out that surveillance, but it's important, it's imperative that they continue to come see us so that we can stay on top of any issues as they arise. And then this is just a patient that I share with one of my podiatry colleagues, Dr. D'Onofrio, and just showing the stages of his ulceration, his Charcot arthropathy, and how he led to healing. Thank you.